Yes, doctor, we are live.
Thank you. A very warm welcome to all of you today for our very first case presentation webinar series in oculoplasty. This is an initiative by the Young Ophthalmologist Society Oculoplasty Focus Group. I would now like to invite our team lead, Dr. Puneet Jain, to introduce us who we are and what this initiative is. He is consultant in charge in ophthalmic plastic surgery and ocular oncology services at Sharpside Eye Hospital and is currently based in New Delhi. He did his residency from RP Center AIMS, followed by a fellowship in oculoplasty with Dr. Hunawar at CFS. And then he did his international stint in ocular oncology and ophthalmic radiation at the New York Eye Cancer Center, USA. He's also the executive member of YOSI and the section editor of DOS Times and Haryana Journal of Ophthalmology. He has several awards to his credit, including the AIOS International Heroes Award in 2024 and 2025, and several publications to his name. Welcome, Dr. Puneet. I would now request him to lead the proceedings.
Thank you, Ayushi, for that elaborate introduction. So a very warm welcome to everybody who has joined in and those who are joining in. This is an excellent initiative. So before we go ahead with the initiative, let me just run you through our current governing council at YOSI under the able leadership of Dr. Devakant Mishra, who is our president, and our immediate past president, Dr. Sonal Kalia, our vice president, Dr. Karan Bhatia, our general secretary, Dr. Nilesh, our treasurer, Dr. Aditya Sethi, and our joint secretary, Dr. Prasanna Viramesh. We also have the executive members, 20 of us, young and dynamic and full of energy. And so our joint secretary couldn't join us. He's in Hawaii right now. I'm sure winning some award, and he has a video message for us. Can you play it for us, please? I think the video is not playing, is it?
Dynamic, and we are very happy.
Is the audio playing?
Just a candid conversation between two of us.
Can you hear the audio?
Yes, it is audible. Yes. Play.
And here we are with the ExPresYO, where the young ophthalmologists are mentored by expert panel, and you are guided at a step-by-step level on a case presentation where you get to network and foster collaboration. 3 cheers to the entire oculoplasty focus group and the ExPresYO team and Team YOSI. Thank you for having me here, and I'm pretty sure we are going to rock. 3 cheers to the team. Thank you.
Thank you, Prasanna, for that wonderful message. So this is a rough layout of the current how YOSI works. So there are a lot of arms in YOSI now, and one of the arms is these presidential focus groups, one of which is oculoplasty focus group. So can we have the next slide? So the oculoplasty focus group, we have the following team members. We have Dr. Nupur Goel, Dr. Rituja. Can we go back to the previous slide once, please? Since this is the first episode, I really want to pause on this slide. So we have Dr. Nupur Goel, we have Dr. Rituja, we have Ayushi, who just started the series a couple of minutes back. We have Dr. Rolika and we have Dr. Shruti. I am the team lead. So Dr. Rituja, a bit about Dr. Rituja. Dr. Rituja is an oculoplastician, orbit consultant at Vision Eye Center, New Delhi. She has received her super specialty training at Narayana Nethralaya, Bangalore. She has numerous publications and book chapters to her name, and it is also an award winner in national and international conferences. She is a member of various national and subspecialty societies, as well as editorial board member of DOS Times and DGO, and she is also a key member of the oculoplasty focus group at YOSI. Dr. Nupur Goel needs probably less introduction than us. She is a very, very vibrant and active member of YOSI. She is an anterior segment and oculoplasty surgeon at Eye Care Noida. And she is also an alumnus from LV Prasad, where she did a long-term fellowship in this super specialty. She takes keen interest in academics and teaching. She is also holding a lot of positions. She is an executive member, or current executive member of, past executive member of YOSI. She is the editor of NOS Times. She is also the team lead in YOSI Socio-Cultural Group and YOSI IROC Group. And she is also the managing editor of Yo Times. Next we have Dr. Ayushi, whom you have all seen. She's currently in Kolhapur. She's in Maharashtra right now, where she's consultant oculoplasty, facial aesthetics, and ocular oncology at Nanda Deep Eye Hospital and PG Training Institute. She's also a LV Prasad alumnus. Where she also served as a chief clinical research fellow. She's a clinical researcher, active clinical researcher who successfully concluded the Global Clinical Scholar Research Training Program from the Harvard Medical College to 20 Medical School 23-24. She has numerous publications to her name and numerous awards as well. She's an active participant in international and national conferences, and she's also an executive member of YOSI and editor-in-chief of YOSlides and member of the YOSI Research Cell as well. Next, we move to Dr. Olika Bansal, who will be returning with us to India soon. She has done 2 international fellowships, one which just concluded at the US UCSD San Diego, California, and also Ocular Oncology Fellowship at the Wills Eye Institute in Philadelphia. She has done a long-term oculoplasty and ocular oncology fellowship under the able leadership of Dr. Santosh Anawar at Center for Sight, Hyderabad. She has won numerous awards in ophthalmology, 64 to be precise, including national and international awards. She is a centurion when it comes to research projects, and she is an executive member of YOSI, member of the YOSI committee, research committee, as well as oculoplasty focus group. Last, we come to Dr. Shruti. She's a consultant in oculoplasty at Girdhar Eye Institute, Kochi, Kerala. She is also an long-term fellowship alumnus from LV Prasad Eye Institute. She most recently won the Sujata Savitri Rao Award for Best Paper in Oculoplasty at a recently concluded APOS meeting in Delhi. She also has numerous awards to her name. Now coming to what is ExPresYO. So this group came into being over a casual conversation. I still remember very distinctly the conversation, and it has eventually materialized into ExPresYO now 6 to 8 months later. And the purpose of this group is so that the residents and fellows from all medical colleges, not from select medical colleges, which actively participate in various webinars, conferences, where they can be mentored, can have mentored presentations. And in this group, we specifically restrict ourselves to oculoplasty and ocular oncology. It's a unique initiative in a way where the mentor-guided case presentations are presented and discussed and will be discussed. Now, we have also made this competitive because I feel that wherever there is the competitive spirit, it improves your efficiency when you're presenting, and also you look forward to what's next. We open the first, can we go back to the slide? Just 2 more seconds. So we opened the abstract for the first session and they were submitted by 9th. And we are starting with our first webinar, the theme of which is lacrimal system. So I'll go ahead and introduce our moderators. One of them is Dr. Ayushi Agrawal, and we also have Dr. Prerna Sinha, who is a consultant in oculoplasty and orbit and ocular oncology at Akhand Jyoti Eye Hospital in Bihar. She is again an alumnus from LV Prasad Eye Institute. She is also ex-senior resident AIMS Patna. She is a university gold medalist in MS ophthalmology from the prestigious VMC and Safdarjung Hospital, Delhi. She has numerous publications to her name and is also a core member of the YOSlides team. I think I'll hand over the baton now to our moderators. Wish you all the best, and thank you all who have joined in, and look forward to an active participation in the coming webinars. Thank you so much.
Thank you, Dr. Puneet. Before we start our first case, I would like to introduce our expert panelists for today. So first we have Professor Ruchi Goel ma'am, who does not need any introduction. She is the mentor of all mentors and the teacher of all teachers, and the precise reason why I am into oculoplasty. Currently, she's a senior consultant at I7 Group of Hospitals and also at Rajiv Gandhi Cancer Institute. She not only won the honorary FRC of the degree, but is also the examiner of FRC of. She has served as the director professor at Maulana Azad Medical College. New Delhi, and is a reviewer of several peer-reviewed high-end journals. She has more than 100 indexed publications with more than 33 book chapters and 3 CME series by AIOS. She's also the editor-in-chief of the Manual of Oculoplasty, go-to book for all PGs and fellows who are interested in oculoplasty, as well as the famous Manual of SICS. She has won several awards, and notably Dr. VP Chadha Memorial University Gold Medal, Srimati Rukmani Gopalakrishnan Memorial Gold Medal, AIOS APO Honour Award for Best Paper in Lacrimal Session, AIOS IGO Silver Award, and Outstanding Paper by the International College of Surgeons. Welcome on board, ma'am. Then we have Dr. Joya, who's a senior consultant at oculoplasty and the orbital department at Disha Eye Hospitals in Kolkata. She has done her long-term fellowship from Disha Eye Hospitals, followed by a consultancy at Shankara Eye Hospital. She has also served as the head of the department at the oculoplasty and orbit services at Sadguru Netra Chikitsalaya, Chitrakoot, and has published in many high-index journals. She's also a reviewer of several high-end journals and has won several awards, notably the Best Poster Award at AAO 2024 and Best of Show Award in AAO twice in a row at San Francisco, as well as Chicago. She also won the Best Paper Award in Kolkata Academy of Ophthalmology and also the AIOS International Ophthalmic Heroes Award in 2024. Welcome, ma'am. Then we have Dr. Raghuraj Hegde sir, who is currently the head and senior consultant in the Department of Ophthalmic Plastic Surgery, Oncology and Orbit at Manipal Eye Hospitals, Bangalore. He also is the adjunct faculty and in charge of the department at Kempegowda Institute of Medical Sciences in Bangalore. He is also a senior consultant in the oculoplasty services of Dr. Modi Charitable Eye Hospital in Bangalore. He has done his fellowship from the prestigious NUHS Singapore under the mentorship of Dr. Gangadhar Sundar. He is currently one of the directors of the Vision Mission, which is a non-profit organization based on 3 wings globally, and is dedicated to providing eye care solutions to underserved areas in Africa, South and East Asia. He's also the executive council member of APSOPRIS. Welcome to all of you there. And now I would like to request Dr. Prerna to start the session.
Thanks, Ayushi. Good evening, everyone. We shall now begin with the case presentations. I would like to invite Dr. Shivani Shadangi, a third-year ophthalmology resident at GMC Nagpur currently, for the first case presentation. Shivani has participated and presented at various conferences at regional and national levels and has a few awards to her credit. So over to you, Shivani.
Good
Please
evening.
share the screen.
Yes, ma'am. Good evening, ma'am. Is my slides visible?
Yeah, you can start.
Okay. So good evening, everyone. I would like to extend my heartiest gratitude to all my mentors. Let me start with my today's case presentation, that is on a spontaneous resolution of congenital bilateral dacryocystocele by conservative management. There is no conflict of interest to disclose, and the images used in the presentation has been taken with due consent. These are the abbreviations that has been used in the slides. Congenital dacryocystocele is a rare variant of nasolacrimal duct obstruction, and it has female predilection, is usually presented unilaterally and can present at or shortly after birth. There is a possibility for intranasal extension that may cause respiratory distress requiring surgical intervention. Therefore, nasal examination is important. However, these are benign in condition and are easily treatable after birth. Its antenatal detection is of utmost importance, as highlighted in this case presentation, as it may have syndromic associations such as Down syndrome, Canavan's disease, dysplastic kidney disease, etc. So here's a story of a 23-day-old female infant brought by parents to our IOPD services who presented with bilateral swelling over the sac area since birth, which was diagnosed accidentally in the antenatal scan. So this is the antenatal scan showing reduced femur length as marked with yellow arrow. This scan was done at 30 weeks, which was suggestive of fetal intrauterine growth restriction. So a 4D prenatal third trimester scan was done. And guess what? What would have it revealed? It revealed the presence of approximately 5 to 6 cystic swelling, which was present inferonasally in bilateral sac area. So birth history was uneventful. Pediatric evaluation was suggestive of low birth weight. Ophthalmological examination was done and it revealed presence of bilateral firm, non-erythematous, non-pulsating, bluish cystic swelling present below the medial canthal tendon, and it was Rho plus negative and it was not associated with any other abnormality. This image shows firm bluish cystic swelling in right side of size 12 into 10 mm approximately as marked in the image, and in left side of size 10 into 8 mm, and it also demonstrates presence of upward slanting of bilateral lower lid. So there was no presence of craniofacial abnormality or hypoplastic maxilla or cleft lip or palate. So we could think of differentials like it could be dacryocystocele, dacryocystitis, encephalocele, ethmoid mucosal, a dermoid, or a hemangioma. ENT opinion was taken and endoscopy revealed that there was a bilateral clear nasal cavity with normal nasal mucosa with no presence of intranasal cyst. After carefully ruling out all the differentials based on clinical diagnosis, we could conclude that it was a case of congenital bilateral dacryocystocele without the presence of an intranasal cyst or any communication. So we started with locally eye drop antibiotics, both eyes, to prevent any secondary bacterial infection. Warm compresses were given in bilateral sac area. Crigler lacrimal sac massage was done, and we continued the same treatment. Parents were also educated about the proper techniques and adherence to the treatment. So at 3 weeks, we could see that there was complete resolution of left-sided swelling. However, there was minimal resolution of right-sided swelling. We proceeded with the same treatment and we could see that there was some resolution in the left-sided swelling. So at the time of presentation, we could see that there was presence of bilateral cyst. And at 3 months, we could see that it was completely resolved bilaterally and there was no recurrence at 6 months or 1 year of age. As dacryocystocele may be a part of numerous syndrome, its prenatal visualization raises the rare possibility of associated anomalies. Early diagnosis allows for planned intervention and counseling of the parents, and medical management can be effective in treatment of the congenital dacryocystocele. So this is a review of literature done by Swati et al. In the year 2019, which was published in Ophthalmologic Plasty Reconstructive Surgery Journal. And it shows that it concludes my case that conservative management is helpful in maximum of the cases as highlighted with the red boxes. However, some of the cases required probing under anesthesia or marsupialization of the cyst if present. So my take-home message would be conservative management is preferred. Antenatal detection can help us diagnose its syndromic associations. Multidisciplinary approach is required, and prompt referral from a pediatrician or a radiologist is appreciated. Thank you so much.
Thank you, Shivani, for the beautiful case presentation.
Yes.
I would now like to invite Dr. Joyita Das ma'am to comment or ask questions to Shivani.
Yes. Yeah. Dr. Shivani, very nice presentation, very unique case, especially you have yeah. Am I audible?
Yes, ma'am, you're audible.
Yeah, okay. Yeah, it's a very nice case presentation, and especially the prenatal ultrasonography picture is very unique. But I want to ask you one thing: what is the indication of prompt surgical intervention in a case of dacryocystosis? Where
Ma'am,
you'll yeah.
There may be many indications, like if the
Yes.
baby is presenting with respiratory distress, which is the first and foremost important indication. Second, if there is, we are planning for some surgeries like presence of congenital cataract or glaucoma, then we need to operate the patient. If there is a presence of recurrent dacryocystitis, or if the patient is positive ROPLAS with mucoid discharge despite giving intravenous antibiotics or local antibiotics, and also if the parents are apprehensive and require some aggressive management.
Thank you, Dr.
Why? Yeah.
Yeah.
Why
Yes.
there may be yeah, Dr. Shibani, why there may be respiratory distress in those child?
Ma'am, respiratory distress can be secondary to a communicating intranasal cyst that is
Yes.
present. And since this is a case of bilateral dacryocystosis, so the presence of intranasal cyst is more.
Yeah, actually, these children they are obligatory nasal breather.
Yes,
So
ma'am.
whenever you have some obstruction in the nasal cavity, it is very dangerous for them. So you have to take care of that. Okay, thank you.
Thank you. I would now like
Thank
to
you,
invite Ruchi ma'am for her questions and comments.
So, very nice presentation, Shivani. And just to add to it, again, of course, most of these would be managed conservatively. The problem occurs because many of these patients, it is sometimes, difficult to give them general anesthesia also because of associated abnormalities that they carry. And in fact, you had submitted the abstract there where you said that this could be helpful in diagnosis of other abnormalities. I would say that mere presence of this abnormality does not indicate
Yes, ma'am.
so it may be just an association,
It
and
just
yeah, so that part needs to be a little modified in your
Yes,
abstract.
Yes, ma'am.
And suppose you really need to go in for a surgical intervention, what kind of surgical interventions would you like to do, and how would you like to proceed so that you don't end up doing a blind procedure?
Yes, ma'am. So keeping this case in mind, suppose if I need to proceed with a surgical intervention, I would like to wait for at least 18 months, but some of the authors also argue that we could go for a early probing and syringing. That could be at 6 or 9 months, but ideally we can wait for 18 months, and then we can try for probing and syringing. If probing and syringing, if it fails for two or three sittings, 6 weeks apart, we can plan for balloon dilatation or placement of a silicone tube, which can be unicanalicular or bicanalicular. And if even that fails, we can wait for 3 to 4 years of age, and we can proceed with the external DCR or an endoscopic DCR, ma'am.
Okay, I was actually looking for, I think, balloon dactyoplasty and all these. I think it would be more relevant to do an endoscope guided probing and syringing, and if required, you can go in for, maybe a debridement if it's associated with a cyst with an
Yes.
endoscopic visualization. I think that I was expecting that kind of an answer, but yeah.
Yes, madam. Yeah, endoscope is very much important in these cases.
Yes, ma'am.
Endoscopic examination.
Yeah. You can go to the next, yeah.
Thank you, Shivani. Please unshare
Thank
your
you so
screen
much,
so
ma'am.
that the next presenter can share.
Yes, ma'am.
Dr. Prerna, would you like to invite
Yeah,
the next
very well presented and mentored by Dr. Shruti. I would like to now invite our next presenter, Dr. Priyadarshini Patil, who is pursuing a comprehensive ophthalmology fellowship from Nandadeep Hospital, Sangli, Maharashtra. She has done a PG from NKP Salve Medical Institute and Research Center, Nagpur, and presented scientific papers at various national and state level platforms. She is a keen presenter even in YOSI Journal Club sessions. So over to you, Priyadarshini.
Your screen is visible. You can put it on slideshow. Your slides are moving. You can start from the beginning. Yeah. You're not audible. Okay. Yeah.
Is this okay?
Yeah, please continue.
Yeah. Good evening, everyone. Today I'm going to present an interesting case of recurrent acute dicryocystitis, a multi-pronged approach. Slide 7. A 47-year-old lady who is a homemaker by occupation came to the OPD with complaints of recurrent medial canthal swelling in the left eye since 4 months, which was associated with discharge and watering since 4 months. She was known case of uncontrolled diabetes mellitus since 2 years, and she was on intermittent oral antibiotic therapy prior presentation to the OPD. She had left eye ptosis repair surgery in the childhood. Her family and personal history was not significant. Her general and systemic examination was within normal limits. On ocular examination, our best corrected visual acuity in both the eyes was 6/6 for the distance and N6 for the near with normal head posture. So on adnexal evaluation of the left eye, we noted elevated erythematous lesion predominantly in the inferomedial aspect with slight extension above the medial canthal tendon. Also, we noted edema and erythema extending to the upper eyelid region and with rest rear meniscus height, and there was a residual unilateral left eye moderate ptosis. On palpation, swelling was ill-defined, fluctuant and firm in consistency. Tenderness was present and rhoplus was negative. So on ptosis evaluation of both the eye, we noted moderate ptosis in the left eye with lid lag in the down gaze with 12 millimeters of LPS action and good Bell's phenomena, and ocular motility in both the eyes was full and free in all the gazes. The rest of ocular examination was unremarkable. So based on my clinical examination, we established diagnosis of left eye recurrent acute dicryocystitis with lacrimal abscess and preseptal cellulitis with presbyopia. So we aspirated the abscess using 24 gauge needle and obtained 1 ml of purulent fluid and simultaneously started on oral antibiotics. We planned for early endoscopic DCR, but due to her uncontrolled blood sugar levels, surgery got postponed. So we reviewed the patient at 5 days. On her day of surgery, as you can see, the swelling has been reduced and it is less tense and tender. So we underwent uneventful endoscopic DCR with intubation under general anesthesia. Postoperatively, we gave her routine antibiotics, topical and intranasal steroids, nasal decongestants, and oral antibiotics, and she was asked to review at 1 month. On 1 month follow-up, there was a resolution of epiphora with patent lacrimal irrigation, and there was no delay in fluorescein dye disappearance test. However, swelling over medial canthal area was still persistent. So we performed nasal endoscopic evaluation. On this, fluorescein endoscopic dye test was positive on irrigation, but we noted a giant superior age granuloma which was surrounded by the inflamed tissue. So we excised this granuloma and injected intranasal triamcinolone acetonide and restarted this patient on intranasal and topical steroids and gave her very short tapering course of low dose oral corticosteroid therapy. So 2 weeks later, you can see there is a reduced swelling, and on endoscopic evaluation, granuloma was resolved. So we continued intranasal steroid for 2 weeks. So in a final follow-up of 2 weeks, medial canthal swelling was completely resolved. And on endoscopic evaluation, fundus endoscopic dye test was positive with good ICO dynamicity. There was no cicatricial closure, no ICO threats, and you can see granuloma was entirely resolved with a FICI grading 5/5, which is excellent. So this case highlights multimodal approach of dealing with recurrent acute dicryocystitis. And as per recent literature, our approach to the lacrimal abscess using needle aspiration is minimal invasive and efficacious approach. Also, many authors concluded that an early endoscopic endonasal DCR for managing acute dicryocystitis seems to be as efficacious as delayed external DCR. Also, it provides early rehab to the patients. However, it is unclear whether there is any effect of recurrent attacks in the past on successful outcome. So, through this case, I learned frequent postoperative endoscopic evaluation and early management of osteogranuloma are keys to prevent failure. Hence, multi-pronged approach, including abscess aspiration, early endoscopic DCR, and post-op nasal endoscopic evaluation should be opted for. Thank you.
Thank you, Priyadarshini, for the wonderful presentation and excellently managed case. I would now request Dr. Ruchi Goyal ma'am to comment or ask questions from Priyadarshini.
So, yeah, very nicely managed case and very interesting. In fact, your presentation actually appeared as if it was infective, but later on you showed that it was not an infective pathology and it came out to be a granuloma. So that's a very good learning experience. Now, only thing is there were a couple of things which giving a blanket treatment with augmenting, would you think it is justified, especially in patients who are presenting with acute dacryocystitis, recurrent attacks? So what is the possibility? There would be some kind of a resistance. So any modification you would like to do? A blanket amoxi is not a very good choice actually in these patients. Augmentin I should not use. The clavulanic acid combination that we use for generally. So what is a better approach to it if you want to give antibiotics?
First, ma'am, I will check for the resistance for antibiotics then.
We should always send a culture. Whenever you are dealing with acute cases, you should always aspirate, send cultures simultaneously. So that should be one thing which needs to be followed universally. And, why do you think the granuloma formation occurred in your case?
Ma'am, maybe because of abnormal healing of the ostium.
Okay, did you use MMC in these patients?
Yes, ma'am. We use MMC with Meracil sponge were used with 0.2 mg per ml, and it applied over the ostium edges and kept for the 3 minutes, ma'am.
0.2 is this, would it be a very, is that what you use usually, or with this kind of, I think a higher dose would have, I don't know, are you sure you have performed the surgery?
Yeah. Yes, ma'am.
Okay. So anyway, I think I would suggest, because these kind of patients, you would have all kinds of problems. It's again, as I said, that we had showed in our series where endoscopy really helps, especially in diabetic patients, where you have uncontrolled diabetes. And in fact, besides surgical endoscopy, we found actually that laser DC are even more effective, where even if the diabetes is not controlled, you just make a small opening and it starts draining and the inflammation resolves, and then you can go for a concrete management. But then, giving these patients would have more chances of prolonged bleeding. On intraoperative bleeding is there, on table granuloma formation is there. So uh, do you think the granuloma formation would have, if you look at your picture, it is giving like there is some infective component also in that patient. If you go back to your picture, it's giving an infective look also. So do you think the inflammation was secondary to the obstruction that was created, or was it maybe a residual infection that was left? Because every time you have an infection, some bit of inflammation is there, and you always, if you give steroids, it resolves. Even if you take any kind of a patient, right? It's always a combination of antibiotic and steroids. So do you think it's purely the granuloma, or is it that the infective component was also there and it was just that the two work together? Maybe Ayushi can give a better answer to that.
Yeah, I was going to ask for whom is this question. So, the surgery was uneventful, and to prevent granuloma formation, we made sure that the raw bone is covered with mucosa at all around the ostium. We also applied mitomycin C, and surprisingly, usually acute dacryocystitis bleeds, but this patient did not bleed. I characteristically remember, because I was also surprised that this patient did not have minimal intraoperative bleed. And on post-op day 1, the swelling that we see pre-operatively actually resolved completely. And that is why we were kind of perplexed to see the kind of swelling that she had at 1 month. And the surprising thing was that if it was infection, then there would have been some signs of inflammation externally, like redness or pain, but she did not have any. And she was also complaining that this swelling only is left and nothing else is there. And when we did the nasal endoscopy, there was inflammatory tissue, but there were no like signs of infection per se, like any discharge or crusting or anything like that. And so we went ahead with the intralesional steroid injection, and actually we did not even need to excise the granuloma per se because it was so friable that it just got aspirated with the suction cannula. And when we called her at 2 weeks, that is the last follow-up, it had completely resolved. And this is her last follow-up nasal endoscopy, which does not show any signs of inflammation. So this was the conclusion, and that is why we presented this case, that like, can granuloma cause this much swelling externally? Like, this is also the
Maybe
first time I saw.
take-home message would be like that whenever you're doing acute dracularis cystitis, you should do a late endoscopy to see, because these kind of complications can, and we can give a prolonged dose of intranasal steroids for these patients.
Right.
Yeah, so that should be the take-home message. Very nice presentation. Very good.
Thank
So,
you, ma'am.
yeah, so from this case, now I have started doing my nasal endoscopic evaluation at 2 weeks and not wait till 1 month. Even though I'm going to remove the tube at 1 month, I still call them at 2 weeks to see if everything is okay internally and externally. Thank you.
Thank you, Dr. Ruchi. I would now request Dr. Raghuraj Hegre sir to ask questions to Priyadarshini.
Hi, Priyadarshini. It's a very well presented case. Can you hear me?
Yes, yes, sir.
Yeah, very well presented case and very well managed as well. Congratulations to you and your mentor. I want to know what criteria you use to decide between whether to do an external or a endoscopic. Why was the endoscopic preferred?
Sir, as a patient was a case of uncontrolled diabetes mellitus with the recurrent attacks.
Okay.
So,
But what is the criteria that you have used to decide whether you want to do an external or since you already aspirated the pus and already the patient has it's delayed by 5 days or so. You're not going to be operating the very next day. What is the criteria that you use to decide whether we want to do an external or a endoscopic? And would the external also have had a similar outcome?
sir, as external DCR cannot be done in the acute stages. And the patient needs early endoscopic management. So we went for the endoscopic DCR in acute dactyocystis.
So
And then,
what exactly in the external would be a problem?
so external may cause scar formation because we have to make incision outside. So that may be the issue to the patient later, that it may due to the scar. And there is very less manipulation in the endoscopic DCR than the external. And the bleeding is also minimal.
Okay. So yeah. So what are the other factors you would consider? What would you do any imaging in this kind of cases?
Yes, sir. I would like to do a CT scan also in this patient, as the swelling was extending beyond the medial canthal tendon, to look for any other differential diagnosis, to look for lacrimal sac tumor or any orbital cellulitis or any other differentials.
But was this done for this case?
Yes, sir. CT was done for this patient. We ruled out everything and then decided to go for the early endoscopic DCR.
But more than the CT scan, what else would you do with the CT scan? Like an adjunct?
Sorry, sir?
Adjunct for this, what would be, what the another adjunct would be for the CT scan?
Sir, DCG.
CT-DCG. So the CT-DCG would have been a good adjunct.
Yes, sir.
For this case, so that it would have shown whether but most of the time it would be, you would see where the block is, but in some cases you might sometimes be surprised because there is sometimes a chance of a diverticulum which might also get infected periodically, and the syringing will sometimes be negative, so they might have very symptom-free interval in between, and later on they might go on to have acute infection in between. So CT-DCG would rule out all those other pathologies.
Yes, sir.
Thank you, sir. Just a question. Actually, I don't have any experience with doing CT-DCG in acute cases, because when you are putting either you do it topically when you're putting the dye, or because injecting, we are not going to inject per se the dye because it's an acute attack. So I did not have much experience with DCG, neither my radiologist have, because we are at a new place. So we did not do a DCG. What are your thoughts on the same?
So in this case, just putting the drops would not be beneficial because it will not go into the sac, because the canaliculus as well as the sac is all inflamed.
Right.
So you would not have the lacrimal pump function happening. So in these cases, you should actually drain the sac first. Of course, you've already done the aspiration, so there is nothing in the sac, and just inject into the sac and then image. Then you would see the thing.
Okay.
So you basically take the dye that they use, the Omni Pig, and mix it 50% in normal saline, and then with the injection and the cannula, with a straight cannula is preferred. A straight cannula, you get into the sac and put it. Put the dye in, and then you image it.
Okay. Thank you so much, sir. We'll move on to our third case by Dr. Geetika. Dr. Geetika, you can share the.
Okay. Hello, everyone.
You're audible, Geetika.
Um,
Yeah, you can
hello,
continue.
everyone. Can I start?
Please start. Please start.
Okay. Good evening, everyone. I'm Dr. P. Geetika, and my mentor, Dr. Neha Ghosh from Susila Netralaya. Our topic title is Stent in Time about the management of pediatric canalicular laceration with monocanalicular intubation. Basic anatomy of punctum and canaliculus. Punctum, also known as puncta lacrimalia, which is of 0.2 to 0.3 millimeters diameters, and the upper punctum and lower punctum lies at the medial side of the lid margin. Upper punctum lies 5 millimeters from the medial canthus, whereas the lower punctum lies 6 millimeters from the medial canthus at the junction of pars ciliaris and pars lacrimalis. And each upper punctum and lower punctum drains into superior canaliculus and inferior canaliculus, respectively, which both converge into common canaliculus, later further drains into the lacrimal drainage system. And canalicular lacerations, in 30% of cases, direct canalicular lacerations occur. In 70% of cases, indirect canalicular lacerations occur from diffuse trauma. In 54% of cases, inferior canaliculus is involved due to its anatomical exposure, and in 33% of cases, superior canaliculus is involved, and both canaliculi are involved in 13% of cases. And these canalicular lacerations are commonly involved in boys compared to girls. And the most common causes of canalicular lacerations being blunt trauma, common in adults, sharp objects like glass, metal, fingernails, blouse hooks in breastfeeding children, animal bites common in young children, road traffic accidents, and some surgical complications also accounts for canalicular lacerations. And coming to this, blouse hook injury is a peculiar injury in Indian scenario. This 1991 letter to editor article in the journal Indian Pediatrics, Srinivasan et al. Mentioned that blouse hook injury is a rare and unreported cause of canalicular injury in breastfeeding children. And also in 2008, Nayak et al. Mentioned that blouse hook injury is is a cause of canalicular laceration in 20% of patients. Coming to our case, a 2-year-old female child, right lower eyelid injury from accidental trauma with blouse hook 6 hours ago. On examination, she has full thickness lower eyelid laceration of 20 millimeters length involving the medial 2/3 of eyelid with involvement of inferior canaliculus. Anterior segment and fundus are within normal limits, and child's vision is normal as she has shown fixation to the light. Later, wound is thoroughly cleaned and dressed. Injection tetanus toxoid instituted immediately, later followed by systemic antibiotics, and later inferior eyelid tear repair with monocanalicular intubation under general anesthesia was done. And this is surgical video of canalicular laceration repair with monocanalular intubation. Local anesthesia infiltrate to achieve hemostasis. Punctum identified dilated with punctum dilated. Lateral cut end of canalicus is identified with Bowman's lacrimal probe. Now we have to identify the medial cut end of canaliculus. This is the medial cut end, calamary ring sign, white ring-like rolled mucosal edge. Later monocanalicular stent, trimmer to the desired length. Here we used Oro stent. And the collar of the stent anchored at the punctum. Later, pericanalicular sutures are placed to keep the stent in place. Later, the wound is closed layer by layer. Post-operative wound care is explained to the patient's parents. Later, prescribed oral antibiotics, topical steroids, lubricants. Coming to the follow-up, 6 weeks later, shown good cosmosis, no epiphora, stent in situ removed in OPD under topical anesthesia. Clinical periods from this case, high suspicion zone, always suspect canalicular injury in any trauma within 8 to 10 millimeters of medial canthus, even if the injury appears minor, and prompt surgical repair within 24 to 72 hours is ideal to restore function, proper function, and 5 days with close monitoring to prevent infection. Shown in some cases also shows good results. Surgical peril in this case, calamary ring sign seen at the medial cut end of canaliculus appears as white ring-like rolled mucosal edge, and it acts as a surgical landmark for intubation. In case if you can't identify the medial cut end of canaliculus, you can inject air or fluorescent viscoelastics to the opposite punctum. So canalicular injury repair alone is not enough. Intubation is must to maintain canalicular patency during healing, aids in correct alignment of canalicular ends, and also it prevents scarring or obstruction of the lumen. So what happens if the canalicular laceration repair is done without intubation? It can lead to fibrosis, canalicular obstruction, and chronic epiphora, and possible retraction, eyelid retraction in some cases. And this is a case presented to OPD with complaints of chronic epiphora who has a history of canalicular laceration 6 years ago that is not repaired with intubation. So what type of stent to use? Monocanalicular stent is the preferred stent of choice, ideal for isolated lower or upper canalicular injuries, and it can also be used in bicanalicular injuries as well, as it is less traumatic. The collar of the punctum should be, the collar of the stent should be anchored at the punctum. And take clinic message from this case, always examine for canalicular injury in any medial eyelid trauma. Never assume it to be superficial, and early surgical repair is crucial. Delays lead to poor outcomes, and microsurgical stenting is the gold standard. Misdiagnosis leads to epiphora, scarring, possible eyelid retraction, and societal awareness regarding blouse hook injury in infants is important in the Indian scenario. Thank you.
Thank you, Gitika, for an excellent presentation. I think Dr. Ayushi got disconnected earlier. So Gitika is currently pursuing her fellowship in oculoplasty from Sushila Netralaya and is being mentored by Dr. Neha. I now request Dr. Raghuraj Hegre to ask questions to Gitika.
Hi, Geetika. Very
Hello,
well
sir.
present,
Hello,
very
sir.
well presented, and very well managed as well.
Thank you,
So
sir.
how much time do you have once the canonical laceration is occurred for you
6
to
hours,
intervene?
sir, in our case.
No,
In our
how much
case, we
time? No, how much
intervene
time do
within
you have? So I'm asking, what is the time period that you have that you need to intervene between the injury and the intervention?
probably
Till what
24
time?
to 72 hours is must, sir. To
What
achieve better outcomes, 24 to 72 hours is must.
what
So in
what is
some
the
cases,
what are the problems you will encounter if it's more than 72 hours?
more than 70 hours also, there are few cases where the intervention has occurred, intervention has taken 5 days or up to 11 days later, but they have also shown successful outcomes, but there are probably chances of punctal stenosis or irregular patency compared to early interventions.
Main problem will be the granulation tissue setting in. So after 72 hours, you will have difficulty
granulation
in getting the edges together, and cheese wiring of the tissues can occur when you're doing the peripunctal
yes, sir.
tissue. Two things I noticed in the video. One thing is that you have cut the stent, right?
Yes, sir.
To reduce the size of the stent. So actually, if you reduce the size of the stent, it actually, as you're suturing, it tends to keep coming out. So the better way to is to keep the stent intact, as the size, and feed it into the sac, so that it rolls within the sac, and then it holds it together. So the chances of it coming out are much lesser. And yeah, so that is one thing. And also sometimes especially in this one, there is a small medial part of the canalculus that is preserved. In many cases, when there is an avulsion injury, there is the proximal part will actually be at the exactly at the medial canthus itself. So in those cases, it is important that you attach the peripunctal area on the posteriorly to the medial canthal ligament. So those are the 2 points, just 2 comments only. Other than that, everything seems to be nicely done.
Okay, sir. Thank you, sir.
Thank you, sir. Dr. Joeta, would you like to ask Gitika something?
How long would you like to keep the stent?
Probably for up to 6 weeks, ma'am.
Okay. Is there
Up
any
to 6
problem?
weeks.
Yeah.
Better.
Yeah. Is there any additional benefit if you keep it more than 6 weeks, like 2 months, 3 months? Is there any added benefit or not?
After 2 months, 3 months, there might be possibility of.
I can't hear.
Dr. Kitika, can you repeat? Dr. Joeta,
Yeah, we can. Yeah, can you please repeat?
Gitika, your answer was not clear. Can you please repeat?
I think she, can you, I'm not clear
Yes,
what.
ma'am. Yes.
Dr. Neha, can you, do you know what she said?
Dr. Neha, before you comment, I would just like to say a few words. So Dr. Neha is the Chief Consultant at Ophthalmic Plastic Surgery Service at Sushila Netralaya Group of Hospitals. And she is again an alumnus of LV Prasad Eye Institute. And she has special interest in ocular oncology and orbital diseases and has more than 12 PubMed index journals, publications in these journals. And yeah, Dr. Neha, your comment, please.
So Geetika, do you want to repeat what you said?
Yes, ma'am. Madam, the possible complications if the stent is kept long, there is a possibility of formation of biofilm later, which can probably difficult to remove the stent. So early removal of stent is required.
Yeah, I mean there is an ideal period which is between 6 weeks to 8 weeks is what we like to follow. There is no additional benefit as per our experience to keep it longer than that. And there is an additional problem of a biofilm formation that can happen, which can lead to further, maybe there may be a secondary infection or
granuloma formation.
Yeah, granuloma formation, stent extrusion. It's better to remove it at the stipulated time.
Dr. Joeta, would you like to ask anything more?
No, ma'am, you can go ahead.
Thank you.
Thank you, ma'am.
Dr. Neha, just had a question. What is your preferred way of localizing the medial content of the canaliculus? Like we have a lot of ways that we can use.
Yes.
What is your preferred way?
Yeah, thanks, Prerna. So I think, like we showed in the video, so if it's an acute injury, it's a very recent injury, then usually finding the cut end is not that difficult. So just visualization under the microscope is really enough with your, and I use 0.3% brimonidine every time. I use local anesthetic, even if the patient is, even if it's a child under general anesthesia, I'll use some local anesthesia with epinephrine, which also blanches the surrounding blood vessels and gives you a really good visualization. If your assistants are retracting well, I think that calamari ring sign is seen most of the time if it's a recent injury. And I always do it under microscope. That is one thing that I would always suggest, that never try to do a canalicular repair by naked eye or under loops. And if it is an old injury, or if it's been a few days and there's a lot of granulation tissue, then probably, like how Geetika mentioned in her presentation as well, you can cannulate the other punctum and then push some fluorescein dye into it and try to localize from where it's coming out from the other edge. So these are the typical things that work well.
Thank you.
Ruchi ma'am, would you like to give any final comments on this case before we move on to Dr. Martin's case?
I guess the only comment I would like to give is that I think all residents, irrespective of their oculoplasty or any specialty of ophthalmic surgeons in training, they must learn canalicular laceration repair. And thankfully nowadays, with Indian-made stents of this design coming into picture, we should have them freely available. Earlier on, we used to, when we were residents, we were putting those intracats, and they used to traumatize the canaliculus more than what they would cannulate. So that was a difficult period. And as we all want it to be done early, but many of these patients do present late. And in fact, even I have repaired after 2 weeks or so, and you should always give it a try. And of course, these are very good tips that you should do a local infiltration of xylocaine with ADR and put some brimonidine drops. These things really blanch, and they help in visualization of canaliculus. So whenever you're looking for a canaliculus, that is another important thing. It's quite superficial in location. So most of the time I've seen, residents, they're just poking their probe here and then. So try to, poke instruments less and visualize more, clean it up, and then visualize and do the cannulation. So that is the key, because every time you put in a probe touch somewhere, you will have everything will look like a canaliculus after a while. So that is another important thing. And I guess this is the standard management, and we all are doing it. So very nice presentation. Yeah.
Thank you so much, ma'am. Dr. Geetika, can you unshare your screen? While Dr. Martins is sharing his screen, I would like to request him and invite him. He's a resident doctor in ophthalmology at OAUTHC Institute in Nigeria. He's also the Associate Fellow of the National Postgraduate Medical College of Nigeria and a member of the West African College of Surgeons. He is a dedicated researcher who actively engages in community service and programming enthusiast as well. So, and he's being mentored by Dr. Bola. She has mentored several fellows and has also been part of LV Prasada Institute family. Over to you, Dr. Martins.
Thank you, ma'am. Good evening, the expert panel, the mentors, moderators, and everyone. I'm Martins Jason Boff from OETC in Nigeria, and I'll present hemorrhagic lacrimal gland cyst as a rare ophthalmic manifestation in undiagnosed sickle cell disease. Is a case report on the patient. I have no conflict of interest to declare, and patient's written consent was taken for this report and to use clinical photos and imaging. As a way of introduction, lacrimal gland cysts, also known as dark rub, are rare benign fluid-filled lesions of the primary or accessory lacrimal gland and may cause symptoms like swelling, proptosis, ptosis, or discomfort in the patient. Hemorrhagic transformation is rare, but when it occurs, it can mimic serious obstructive condition, and clinical suspicion is very important. Sickle cell disease is hereditary hemoglobinopathy in which a single amino acid substitution in the beta chain of the globin molecule cause the red blood cells to become sickle and form rigid under conditions of hypoxia and acidosis. When this occurs, the cells tends to block capillaries and could lead to infarction. Ophthalmic involvement of sickle cell, which include retinopathy, anterior segment ischemia, glaucoma, and angiohysteria, and optical manifestation like infarction of the optical bone have been well documented, but to our knowledge, there have not been any established link between sickle cell disease and hemorrhagic Jacobs, which in the literature. So the objective of this case report is to report a unique case of hemorrhagic lacrimal gland cyst in a patient with undiagnosed sickle cell disease and to highlight the diagnostic challenges and multidisciplinary management of the case. This was the patient I had presentation. He is a 20-year-old male student presenting with 4-week history of gradually increasing right eye lid swelling with 2-week history of eye pain and reduced vision, associated history of protrusion of the right eye, and low-grade intermittent fever with frontal throbbing headache and catarrh of 1-week duration. There was eye discharge, foreign body sensation, and photophobia. The patient had instilled urine to the eye about 2 times before presentation, and had also visited 2 peripheral centers where he had some form of treatment, but there was no improvement, and he was referred to the oculoplastic clinic. There was no history of trauma or previous ocular surgery. He had history of non-specific painful crisis, which occur like once in a month, and relief with use of analgesic. He is the only child of the mother. The father is deceased. Cause of death was said to be road traffic accident. So the genotype of the father was not known, but the mother genotype is AS. On presentation, he was in mild painful distress with no peripheral lymphadenopathy. He had the right non-ACR proptosis with restriction of extraocular muscle motility in all direction of gaze. The proptosis measured about 24 millimeter on with LTELs, and there was inferior globe dystopsia with lack of thermos of 27 millimeter. He had chemosis, mucoid discharge, conjunctival hyperemia, and special keratopathy with corneal ulceration. The facial acuity was hand motion, and there was presence of hypopium in the anterior chamber. The investigations were ordered for, and hemoglobin genotype revealed that the patient genotype is HBSS. The white blood cell count was 11,200 with left shift and toxic granulation, and the red blood cells shows signs of sickle cell disease, but the patient has never been diagnosed before. Other tests remains normal. A CT scan was requested, and the CT scan shows an hypodense connection, which is seen posterior superior to the globe, displacing the globe inferiorly. The hypodense connection was seen to be attached to the lacrimal gland and also displacing the lacrimal gland anterior inferiorly. And the cyst has an enhancing, the collection has an enhancing rim and with bone remodeling. This gave an impression or suggests of a lacrimal gland cyst, and because of the exposure keratopathy, urgent ultrasound was requested for, and the ultrasound revealed a cystic collection, which is this large arrow shown attached to the lacrimal gland, which is this red asterisk with echogenic periosteum. So an ultrasound guided aspiration was done. This is the ultrasound showing the needle for the ultrasound guided aspiration, and a 5.5 mils of water blood was aspirated. This aspirate was sent for cytology, microscopic culture, and sensitivity. Cytology reviews benign cells with no evidence of malignancy, and there was no bacterial growth on culture. The summary of management is as though the patient was placed on topical antibiotics and ochrafenicol over the exposed cornea. The hematology team reviewed the patient and confirmed the diagnosis of hemoglobin of sickle cell disease and placed him on routine hematinics and other malaria prophylactics. Patient had the ultrasound guided aspiration for cytology and microscopic culture and sensitivity done. And because of the fundus finding, patients also had glaucoma workup during the later follow-up section. But after the aspiration of the cyst, patient recovered remarkably, and as at 3 months post-op, the patient the proptosis and swelling had fully resolved. Also, the vision also improved from hand motion during the first day post-aspiration to 6/12 with refraction, and that's 6 months post-aspiration. This case presents a real association between sickle cell disease and hemorrhagic lacrimal gland cyst. To our knowledge, this is the first reported case of hemorrhagic lacrimal gland cyst in a patient with sickle cell disease. The patient's undiagnosed sickle cell disease and the use of urine installation, which is an amputational remedy, and the delayed presentation for specialist care might have complicated the patient clinical picture. Hence, education on this issue could improve patient awareness and clinical outcome. The lesion clinically mimic an orbital abscess, a tumor or orbital infarction, underscoring the importance of a high index of suspicion for lacrimal gland pathology and need for radio imaging in atypical orbital presentation. This case report suggests that there could be a possible link between vascular fragility and sickle cell disease, which will require further study. Take-home message from this case is that clinicians should consider sickle cell disease in the differential diagnosis of hemorrhagic orbital lesions, especially in endemic areas. These are the references. Thank you for listening.
Thank you, Dr. Martins, for an excellent case presentation and such an interesting case. I would now like to invite Dr. Joyita for her comment or questions to Dr. Martins, please.
In presentation, Dr. Martin, congratulations for that. Here in India, we do not used to see get to see this kind of cases, especially sickle cell related orbitopathy. Thank you for sharing this case. So I just want to ask, this patient actually presented as a case of an infective orbital cellulitis kind of picture. So do you routinely do sickle cell routine test for sickle cell like this sickle cell disease pathology to diagnosis cases in this case, a type of cases like patient presented with this orbital signs, or is it a routine practice in your setup, like in your area?
Thank you, Ma. This patient present like a picture of orbital cellulitis, and routinely we don't order for sickle cell for hemoglobin genotype in such patient. But from the history, he gave an history of recurrent pain, which is relieved with the use of diclofenac, and the fact that he said the mother genotype is AS, and the father is deceased. So then the clinical presentation, he's been treated at our referral center, which are managed by ophthalmologists, and he's been on antibiotics, and there has not been any improvement. Sponsors to look for other causes, and that's why the genotype was requested for. In fact, he had no straightforward features of physical feature suggestive of sickle cell, but because we want to look for other possible cause, that was why it was ordered, and it came out to be. And he also not aware of his genotype. That's why it was requested for.
So is it routinely people used to do genotype or test for sickle cell or any other coagulopathy, like in this case, type of cases?
Yes, ma'am.
Okay, thank you.
Dr. Ruchi, ma'am, do you have any comments and questions?
Yeah, very nice presentation, Dr. Martins. Actually, I have never seen this kind of presentation or even read about it. As far as sickle cell association, maybe you can publish it as a case report somewhere. What really was, what I could understand was that in your scans, I could see the swelling, more of it present superiorly. And if we are talking of dacryops, maybe do you mean to say that it was arising from the main lacrimal gland? This mass, because I don't know the location of the mass. Could it be just that you could not, of course, differentiate the mass from the gland, but otherwise the bleeding could have occurred anyway and anywhere, and it could have occupied the superior orbital compartment and pushed the globe out. Like, how did you ascertain that it is actually a dacryops?
Thank you. From the CT scan, the CT slide shows that the lesion is attached to the wall of the lacrimal gland, and they are sharing the same um, uh, sac, and it was displacing the lacrimal gland anterior-inferiorly. So it's like on the CT scan, it was arising from is a part of the lacrimal gland on the CT scan, and that was what it was also confirmed by the ultrasound, as the sac of the connection is continuous with the lacrimal gland, and when we do the aspirate and the sac collapse, it was as part originating from the lacrimal gland sac.
The swelling should have been more on the, a little infralaterally, slightly more, rather than most of it being superior. So that is one thing. And other thing is maybe the MR would have been a better modality to ascertain. Anyway, since it was an acute case, you could not have done an MR contrast as in those conditions. I understand that. But anyway, very nice and a very rare presentation here.
Thank you, ma'am.
Thank you, Dr. Ruchi, ma'am. I would now request Dr. Bola to share her experience about the case.
Thank you very much. Good evening, everyone, and thank you so much for the invite. We really appreciate being able to present at this very nice program. Concerning the question about the diagnosis, actually, histological diagnosis would have been the gold standard, but we didn't have that option. Maybe if the patient had had a recurrence in a less acute state, then we would have maybe gone and done a surgical excision and removed the mass and sent it for pathology. But discussions with the radiologist, he pointed out the bone remodeling, which pointed to a chronic condition, meaning that the cyst had been there for some time. And actually we had another scan from the ultrasound, which showed post-aspiration, where the cyst completely collapsed, and it was with the lacrimal gland. So maybe we could have added that as well. So combined with the ultrasound findings and the bone remodeling, which showed that the cyst had been there for some time, we actually thought it was possible that maybe the hemorrhage was what really presented in an acute form and caused the proptosis, but the cyst may have actually been increasing in size over time, but we cannot really be sure of that, but that's what we were suspecting. And I think the main take home for me was that we didn't even think it was a lacrimal gland cyst initially. We were suspecting orbital cellulitis, but just as Dr. Martin said, he did not respond to antibiotics, and we were trying to save his vision, and that's why we also had to move quickly. If not, I know surgical excision with histopathology would have been the ideal setting, but in order to save his vision, and at least because he's a young man, give him good vision in that eye, that was why we rushed to aspirate. So we actually aspirated thinking that there would be a risk of recurrence, and he had been well counseled about that. So we were actually pleasantly surprised that there was no recurrence. And so that's why we thought this was an interesting case to present. And I really appreciate all the inputs. And if I may, I just want to acknowledge members of my department. We're about 10 of us on this channel, including a senior consultant, Dr. Badmos, who is a pediatric ophthalmologist. So I just wanted to acknowledge their presence. Thank you so much.
Thank you, Dr. Bola. Just to add, maybe you can do a contrast MRI now and see if there are any signs of, if you want to publish, maybe these same questions would be asked by the reviewer. So you can just get an MR contrast done, and maybe you can show some kind of a track where, there was originally a cyst. So maybe that can help.
Thank you, ma'am.
Hi, Dr. Bola. Can I add a comment, please? It's such an interesting case. Thank you so much for the presentation. So how common is this, ocular and orbital presentation? Like, what are the most common presentation? Is it like this, like the hemorrhagic chemosis that you've shown?
So this is also the first case I've seen, or maybe I didn't get your question very well. Is it lacrimal gland cyst, you mean?
No. The sickle cell disease.
This is the first case of proptosis I've seen in sickle cell. What we commonly see are the ocular features, anterior segment features, and the retinopathy. So this is the first case of orbital manifestation seen in sickle cell disease, in my experience.
Exactly do the ultrasound aspiration, ultrasound guided aspiration?
How we did it? Okay, so we did it in conjunction with the radiologists. So we infiltrated the orbital area with local anesthetic. Then we used an 18-gauge needle. So they applied the probe. So we were doing it in real time. They applied the probe to the mass. And then we inserted an 18-gauge needle. And when we were sure it was in the cyst, like was shown on the scan, and then we did an aspiration, and we were able to collect 5.5 mils of altered blood. So we split that into 2 specimens, sent one for cytology, sent one for microbiology and culture and sensitivity, just to be sure we weren't missing anything. And then the results came out as benign. And then we continued to watch. The patient was on admission, so we were doing daily monitoring, and we could actually see the proptosis resolving, which we had not seen even when he was on antibiotics. So we monitored him, and then we also tried to address the infective keratitis, because that was also quite, and the infective keratitis was bad due to the exposure of keratopathy. So after the proptosis resolved, we now tried to treat the corneal complications, and then he was eventually discharged, and we kept following him up monthly.
Thank you.
Thank you so much, Dr. Bola. Before we conclude this session, I would like to request Dr. Raguraj, Dr. Joita, and Dr. Ruchi Goel ma'am for their final comments and feedback, if there is any. Dr. Raguraj?
So,
yes, ma'am.
No, please. Dr. Raguraj, please.
Yeah. No, it's a good, all interesting cases, very well managed, all of them. It's a good, a lot of learning points as well, and unusual presentations. That last case was especially rare. It's interesting to know that kind of a case. Otherwise, it's a very good initiative. I think we should have it every few months, at least, to have good exposure for the residents.
Thank you, ma'am. Ruchi ma'am.
Yeah, it's what I would say is that it's not only a good learning experience, because all the youngsters, they need to present at a international podium at some point of time, and it's a very good exercise. And I really appreciate all of you have done and made your presentations, which are I think I couldn't really differentiate which one to give first or which one to give second. They were all well-made presentations, and all the comments were answered very well by the presenters. And I really congratulate the organizers for creating these kind of events, because once they learn to present at these forums, they become more confident to go and present at a later stage. And of course, the structured way of making PowerPoint slides and answering the questions, this is a very good exercise. So congratulations to all of you.
Thank you, ma'am. Joita ma'am.
Thank you, Yosi, for this nice initiative. It's a very nice case presentation, and it's a really, good case, especially the last one. So we have never seen such cases in our scenario, at least. So it's very good. And I think we should practice this kind of program more and more, so that we can, Madam Ruchi Madam has already commented on this. So we should have more or more program like this. Thank you.
Thank you, ma'am. Just to announce that we have an eyelid session next on 20th July with similar 4 case presentations. Now I would request Dr. Puneet to give a short vote of thanks, and then we'll conclude with a mandatory customary YOSI picture.
Thank you so much. I think I would call it a great start. We had national and international presenters both. The quality of the presentation was excellent, and the discussion that ensued was also very engaging. It's a small world. We are, coming closer. And when it comes to our specialty, that is oculoplasty, no one size fits all. So we have a lot of challenges, radiologists, pathologists. We have to deal with so many things. So I think these discussions do bring about those angles as well. Sometimes we presume that, okay, this is direct and this is, available to us. Might not be available, at every place. And then how you manage, discuss, and go forward with the cases. So excellent. Kudos to Ayushi and the entire team for putting this series and starting it on such a good note. I think it's Sunday and everybody wants to go. Me too. So let's take a quick photo. And a special thanks to Ruchi ma'am, Dr. Raguraj and Dr. Jayata for joining in.
Thank you. And I would also like to thank all presenters and mentors for spending their precious time to mentor the mentees. And especially Manjula ji for her support and starting the things on time. I would now request everyone to switch on their video and make this sign, and so that I can take a picture. Can everyone switch on their videos? Dr. Geetika, Dr. Prerna has already. Manjula ji.
Yes, doctor. We'll do the needful.
Thank you, everyone. Thank you for joining.
Take care, doctor.
See you next month.
Thank you, everyone.
Thank you, everyone.
Thank you so much.
Thank you.